How can you reliably and confidently assess for left atrial appendage thrombus with TEE? What tips and tricks can you use in your assessment? Well, this will all be discussed right now in episode 19 of Tea Time. Welcome back to Tea Time. I'm Dr. Andreas Plackis, and in episode 19, we're going to be talking about a left atrial appendage thrombus and how to evaluate it with TEE. The clinical question today is, how do you rule out thrombus in the left atrial appendage using TEE? And if you find this thrombus during cardiac surgery cases, what are your surgical options? Why are we even talking about clots that may occur in the left atrial appendage? Well, as you may know, these can be a significant source of strokes, where up to 90% of clots are seen from the left atrial appendage in non-valvular AFib. Also, regarding patient management, it's important to know if there's a thrombus in this position, as it can influence anticoagulation management, both perioperatively and outside of the perioperative setting. What are some of the risk factors for a left atrial appendage thrombus? Well, they can be thought of in a couple categories, but the first category is stasis or low flow states. This can occur in atrial fibrillation, low cardiac output states, or even with mitral stenosis. Of note here, mitral regurgitation is actually protective from thrombus because of the increased regurgitant blood flow into the left atrium, whereas mitral stenosis would increase the risk of thrombus because of the lower flow through that left atrium. Also, when you see spontaneous echo contrast in the left atrium, this is one early marker that could clue you in that the patient may have a clot present. Finally, in hypercoagulable states, you have to have increased suspicion that this could form. In what clinical scenarios would you consider looking for a left atrial appendage thrombus? Well, especially in a patient with atrial fibrillation in the peri-procedural period, this would be considered in a patient who's undergoing electrical cardioversion. And I'm not going to discuss all the implications around anticoagulation management here, but just think about it when it comes to cardioversion. For an AFib catheter ablation, especially with pulmonary vein isolation, for a left atrial appendage closer device implantation. Other procedures that could involve the left atrium or left atrial appendage, such as a transcatheter mitral valve replacement, a transcatheter edge-to-edge repair of the mitral valve, or a percutaneous mitral balloon commissurotomy. If you're evaluating cardioembolic sources of a cryptogenic stroke, you would want to look in the left atrial appendage. For your perioperative cardiac surgical TEE exam, this is part of your standard assessment. How important is TEE as a diagnostic tool for left atrial appendage thrombus? Well, it's the current gold standard for ruling out a left atrial appendage thrombus with, depending on the study, a sensitivity of 93 to 100% and a specificity of 99 to 100%. There are some areas where TEE is limited as a diagnostic tool. This is when you may have small thrombi, less than 2 millimeters in size, that it may miss, or you have unusual shapes to the left atrial appendage and it can miss distal lobes. And the specificity is limited as well by misdiagnosing large pectinate muscles as thrombi. If you see a mass in the left atrium or left atrial appendage, there's a differential diagnosis outside of thrombus that I want you to be thinking about. Obviously, it may be thrombus, which would be even higher suspicion in low flow states, such as atrial fibrillation, mitral stenosis, or any time there's stasis of blood flow. There could be a tumor where there may be features of a myxoma present. If there's a vegetation that could be attached to the mitral valve leaflets or annulus, it could be a normal variant where you're seeing muscular ridges, pectinate muscles, or trabeculations. Or it could be an artifact that is purely related to your imaging. So this is how I evaluate the left atrial appendage using TEE in a standard fashion. First, to obtain the correct view, I start at a mid-esophageal four-chamber view and center the left atrium in my screen. Then I change my omniplane angle to 45 degrees. You're going to be rotating leftward, as that is the best way to bring the left atrial appendage into view, and then significantly antiflexing the probe from that point will help move the left atrial appendage to a more vertical orientation. It will also move the Coumadin ridge out of the way, so you have less shadowing from that and less chance for artifact. Once you get the most optimal view of the left atrial appendage, I'm going to be looking in 4 different omniplane angles: 0, 45, 90, and 135. I'm going to look in each of these views both with and without color, assessing for the presence of thrombi or interrupted blood flow. Using multiple views is helpful because one specific view may miss an extension or alternative lobe of the left atrial appendage that you cannot see with another one. Then I'm going to perform pulse wave Doppler at the left atrial appendage ostium for ejection velocities. If the A wave velocity is greater than 55 centimeters per second, this has a 100% negative predictive value for thrombus. It essentially means blood is ejecting so well from that left atrial appendage that it will not have thrombus in it. Finally, if there's something I want to confirm in my 2D views, I'll perform a 3D assessment to see if I can get one more view to understand the whole picture of what's happening in the appendage. Let's look at some images of a normal left atrial appendage that does not have thrombus. This patient on the left is in AFib with RVR, but has a left atrial appendage that is closing routinely and ejecting with no thrombus seen all the way down to the tip of the appendage. There's also not spontaneous echo contrast present. When pulse wave Doppler was performed, this patient has significant ejection velocities with an A wave above 55 centimeters per second. A separate patient had a contrast agent given to rule out appendage thrombus, and you can see it fully fills the left atrial appendage with no clot interrupting blood flow. Here are some images of patients that do have clot in the left atrial appendage. Here you can see it obviously where there's this thrombus in the left atrial appendage and even shadowing occurring from it. This next patient has a small thrombus coming from the tip of the left atrial appendage. And this last patient has a very large thrombus that even occurs to be partially obstructing the mitral valve, but it originates from the left atrial appendage. The characteristics that you will see if you're trying to observe thrombus are that it originates from the left atrial appendage, it's homogeneous, it's not attached exclusively to a valve like the mitral valve or the interatrial septum, and that it doesn't act like an artifact. I have a couple tips and tricks that you can use if you're unsure if you're seeing left atrial appendage thrombus or not. The first of which is using a contrast agent, such as Lumason or Definity study. Thrombus doesn't ever take up contrast. You can see this present with the patient in the top clip, where you're not sure if that's just sludge and spontaneous echo contrast, or if it's actual thrombus, and then a contrast agent was given, and you can see this black object in the left atrial appendage. That should not be there. Sludge and spontaneous echo contrast will eventually take up contrast, so that would confirm that this patient has thrombus present. Other tips and tricks to look at are using color Doppler to see flow throughout the entire left atrial appendage. I already mentioned that, so the tip here is make sure you turn down the color scale to observe low flow states. A normal left atrial appendage will not have flow interrupted through it, and it will be contiguous throughout. If there's ever an object in there where flow only goes around this object and not through it, you need to consider this patient possibly having thrombus or large pectinate muscles or other irregularities in the appendage. Also look from multiple omni angles. This will help you rule out artifacts as causes or even help you see clots from a different vantage point. Finally, if you really need help, turn off your operating room lights as well. Sometimes these black and white images are much easier to see with the lights off in the room if you really need to make this assessment for clinical decision making. The final part of these tips and tricks are to optimize your image as best as possible. These will all increase the resolution of your image and allow you to see even fine details in the left atrial appendage. The first is narrow your sector width. Just look at what you need to look at. Ignore things outside the image. This will increase your resolution. Make sure the depth is no deeper than the left atrial appendage. Place your focus at the level of the left atrial appendage and ensure your echo machine is in resolution mode, not gen or penetration mode. Make sure it is in resolution mode so you have the best imaging of near field objects. Let's talk now about some of the similarities and differences of spontaneous echo contrast, sludge, and thrombus that can be present in the left atrium or the appendage. Spontaneous echo contrast is this dynamic smoke-like pattern, this swirling pattern that can be seen in the left atrium or the appendage. And it's when you have red blood cell aggregation in low flow states, this early rouleau formation that can occur. Sludge is when you have gelatinous qualities without a discrete mass. It's essentially a transition state between spontaneous echo contrast and thrombus. You'll have this layered swirling material, but it's less organized or solid than thrombus. There is a strong association between decreased left atrial appendage ejection velocities, left atrial spontaneous echocontrast, and appendage thrombus. These all exist essentially in a family. Spontaneous echocontrast is seen 80% of the time that appendage thrombus is present. One of the ways that you can differentiate these from each other is using contrast. Delayed opacification is seen when you use contrast in low flow states into the left atrial appendage. However, with spontaneous echocontrast and sludge, eventually contrast fills the whole region. This does not occur with thrombus. That is the main way, is using that Definity or Lumason contrast to see if it fills the entire left atrial appendage eventually. If you have left atrial appendage thrombus during the perioperative period, such as intraoperatively during cardiac surgery, what do you do? Let's talk about some of the data that's out there and some of the recommendations. First off, there are no clear guidelines for how to manage this, but there are a couple thoughts and a couple points to remember. If there is clot in the appendage, do not clip or oversew the appendage with clot in it. Next, I would ask, can the left atrial appendage be visualized directly during surgery or not? During mitral valve replacement surgery, you should have direct visualization if you're opening the left atrial appendage surgically. This left atrial appendage, depending on the surgical approach, can be inverted and all the clot can be removed from it. However, if you're performing an AVR or cabbage surgery and you don't have direct access to the left atrium or direct visualization, then you may not be able to do anything to the left atrial appendage, and you may just need to anticoagulate postoperatively as you would with any other patient who has appendage thrombus. Some other thoughts I want you to consider are, would you delay the case for a course of anticoagulation if the surgery can reasonably wait? Remember, these patients having cardiac surgery are at higher risk for arrhythmias such as ventricular fibrillation, ventricular tachycardia, or atrial fibrillation with a rapid ventricular rate, and may need either cardioversion or defibrillation, which is something that you must consider in a patient with left atrial appendage thrombus. There are risks to proceeding with the surgery, just like there are risks to waiting on the surgery. Something for the surgeon to consider: should the surgical strategy be altered in order to minimize manipulation of the appendage and the risk of embolic stroke? If you're doing a cabbage and the plan was off pump surgery, would you consider doing it on pump? There's all factors to consider and weigh together during these cases. That is the end of this podcast episode. The next episode, we are jumping back into our valve series, moving on from mitral valve to aortic valve. In episode 20, we will be evaluating aortic regurgitation, TEE, for aortic valve surgery. I'm excited about this one. This will be a big series coming up. Thank you guys for watching today. If you want more of this content, feel free to hit that subscribe button, write us a comment sharing your thoughts and your experience, and even leave us a 5-star review. That really does help us get this information out to more people. But appreciate you guys watching as always. We'll see y'all next time.